Good evening, everyone. Today we were going to talk about rheumatic mitral stenosis, and not just rheumatic. I also want to touch on all the other types of mitral stenosis. So I just wanted to show you some historical perspective. So the picture on the right is Dwight Harkin. He actually was the first man who successfully do operation on a beating heart. So what happened is that there is a soldier who is wounded in war, and the shrapnel actually pierced the soldier's heart, and he's able to suture the heart back. Now that might not sound remarkable, but actually in the 20th century, the heart is actually a taboo part for a surgeon to touch, so they are not supposed to touch the heart. So after the successful closure of the heart by Dwight Harkin, so what happened, these two characters, Dwight Harkin and Charles Bailey, and both of them are from the United States, they're actually competing to solve the problem of rheumatic mitral stenosis. So both of them tried to do it on patients, and the initial patients actually died. However, Charles Bailey actually managed, so this guy actually managed to beat Dwight Harkin by only 5 days when he's able to put his finger in between a stenotic mitral valve and relieve the stenosis mitral valve. And Dwight Harkin able to do it 5 days after Charles Bailey. So why is rheumatic mitral stenosis or mitral stenosis in general is very important? So number one, rheumatic mitral stenosis is very common in our part of the world. And the diagnosis is often not recognized until it is too late. The problem with female patients especially, they tend to get pregnant without knowing that they have heart problem. And once they get pregnant, only then we find out they have mitral stenosis. As you know that pregnant lady tolerate especially stenotic lesion very poorly because of the fact that the chamber volume is actually limited. Now, as you know, when you get pregnant, the cardiac volume actually goes up throughout the second and third trimester, and then this can lead into pulmonary edema and heart failure as the patient go into usually into towards the third trimester. And if it's diagnosed too late, the problem with mitral stenosis is that the patient can also develop pulmonary hypertension and right heart failure. And if let's say the patient have severe pulmonary hypertension and increase in pulmonary vascular resistance, it might be irreversible. So we would want to catch this mitral stenosis early. So the first thing that I wanted to do is to familiarize yourself with the anatomy of the mitral valve itself. So on the left here is the short axis view at the mitral valve level. And I just wanted to remind you, the part here on the where I point is the lateral part of the mitral valve, and here is the medial part of the mitral valve. So from here to here is from lateral to medial. So for example, this here will be A1 scallop, there will be A2 scallop, and this is A3 scallop of the mitral valve. That's going to be P1 scallop, the middle going to be P2 scallops, and here going to be P3 scallops of the mitral valve. One of the most important thing that we need to see in short axis view is we need to see at the commissure, meaning that where the anterior mitral valve and the posterior mitral valve leaflet meet. At the lateral part, we call it the anterolateral commissure, and in the medial part, we call it the posteromedial commissure. Now, the characteristic of rheumatic mitral stenosis is you will have a commissural fusion at the anterolateral and the posterior medial part. Okay, that is the main problem of rheumatic mitral stenosis, and you have to check that every time you see patients suspected of mitral valve problem. This is the parasternal long axis view, so that's the anterior mitral valve leaflet and the posterior mitral valve leaflet there. This here is the descending aorta. I just wanted to give you some tips. So this shadow here is actually the vertebral bodies, and your coronary sinus is actually here. Now the anterior mitral valve leaflet and the continuation of anterior mitral valve leaflet to the non-coronary cusp of the aortic valve is actually very important. That is your mitral aortic curtain. And why is it important? It actually forms the posterior wall of the left ventricular outflow tract. And the movement of the blood from the left atrium to the left ventricle out to the aorta is actually very dynamic. So this movement has to be synchronized with the movement of the aortic valve. So if you have damage at this mitral valve leaflet, it might give you problems. I also wanted to remind you in terms of the leaflet itself, it shouldn't be thick. So normal thickness of the mitral valve should be less than 3 millimeter. And we also have to be cognizant of the length of the mitral valve. So the average length of the anterior mitral valve leaflet is about 20 millimeter, and the average length for posterior mitral valve leaflet is about 10 millimeter. I just wanted to show you again the anterolateral and posteromedial commissure. So anterolateral and posteromedial. So this is a normal mitral valve. As you can see, there is no commissural fusion. That's just I circle the shadow of the vertebral body. Now let's look at the transesophageal echocardiogram. Okay, in transesophageal echocardiogram, it is actually special. So this part here is actually posterior, and this is anterior. This is actually transgastric view of the mitral valve. So that is going to be your anterior leaflet, and that's going to be your posterior leaflet. So let's recognize the scallop here. So that's going to be your A1 scallop. Then after that, that's your A2 scallop. And finally, that's your A3 scallop. And opposite that, you have P1, P2, and P3 scallop. So this is going to be your anterolateral commissure. Remember, the P1 is lateral, and that's going to be your posteromedial commissure. This transgastric two-chamber view is actually very important in TEE because this is one of the view that you can really assess the chordae tendineae. So the chordae tendineae is the structure that connect the mitral valve leaflet to the papillary muscle. So you can assess how thick is the leaflet, whether the leaflet is calcified or not, whether how thick is the chordae tendineae, whether the chordae tendineae is fused. So this is also one of the view that illustrate well the concept of axial resolution. So when we talk about resolution, there is three types of resolution. So one is temporal resolution. So temporal resolution is how smooth your image is actually moving. So this is usually put on top of your echo on the top right. For example, this one is 53 hertz. This means that the image is moving at 53 frames per second. Just for a comparison, when you do M mode, the frame per second can be up to 2000. So that's why when you use M mode, it's very good to see movement that is very, very fast. Okay, that is temporal resolution. There's another type of resolution is called spatial resolution. There's two types of spatial resolution. One is lateral resolution. So this is the ability to differentiate 2 points that is at the side to one another. So one side this side and this side the other side, and then if you're able to make up that as two separate points. Okay, and axial resolution on the other hand is the ability to differentiate 2 points on top of the other. So as you can see in the picture of the chordae tendineae here, you have 3 chordae tendineae, and you can actually separate the 3 chordae tendineae. So meaning that the resolution is small enough that you can separate the chordae tendineae to each of its components. Okay, so this is something that is good to illustrate axial resolution. Now, this is actually 3D transesophageal echocardiography of the mitral valve. So I just wanted to show you a tips of how to determine which scallop is involved in a pathology. In this example, I show you someone with mitral valve prolapse when you do a transesophageal echocardiogram. So this is actually the mid-esophageal 4-chamber view. So what you do in mid-esophageal 4-chamber view is you determine which scallop, is it posterior or anterior scallop. So this is the posterior and this is anterior scallop. Okay, so that's how you determine anterior posterior. This is actually the bicommercial view. In bicommercial view, you see 3 parts of the leaflet. That is 1 and 2 and 3. So we just number that 1, 2, and 3. So 1 is beside the left atrial appendage and 3 is beside the coronary sinus, lateral and medial. So in this example, you can see that the posterior leaflet is actually flailing into the left atrium, but we do not know which posterior. Is it P1, P2, and P3? So therefore, we look at bicommercial view, and you can see from here, it is the 2. So when we combine this P and 2, so you know it is a P2 leaflet flail. And you can confirm this with 3D echocardiogram here. So you can see A1, A2, and A3 scallop, P1, P2, and P3, and you can see the flail P2 leaflet here. Okay, so this is the surgeon view of 3D echocardiogram. So I hope that is quite clear. Now, this is our first question for the day. So number one, diastolic mitral leaflet domain concave towards the LA is seen in which situation? So what I mean by concave toward the left atrium is this. So there is something that is called the reverse hockey sign. So what happened to the anterior mitral valve leaflet during diastole is it do something like that. So it look like a hockey stick, but it's reverse hockey stick appearance. So that is what I mean. So this is doming. Sometimes the anterior leaflet can have reverse doming as well. So that is reverse doming. Okay. So in which situation do you actually see the doming of the anterior mitral valve leaflet? Is it only rheumatic mitral stenosis? Is it rheumatic and calcific mitral stenosis? Is it rheumatic and congenital mitral stenosis? Or is it rheumatic mitral stenosis and aortic regurgitation with flow impinging on the mitral valve? All right. Now, the answer for this question is some of you might choose rheumatic MS. That is correct, but it is not the only one that caused diastolic doming of the anterior mitral valve leaflet. The other condition that caused diastolic doming of the anterior mitral valve leaflet is congenital mitral stenosis. To be precise, parachute mitral valve. What is parachute mitral valve? It is when the mitral valve leaflet is attached to only one papillary muscle. As you know, each mitral valve leaflet should attach to two papillary muscle, which is anterolateral and posteromedial. So parachute is when it's attached to only one. What about this atrial regurgitation with flow impinging on the mitral valve? So this you will get a reverse doming. So you will you have that kind of anterior mitral valve leaflet. Why is that so? You know that this side here is your aortic valve in parasternal long axis view. So when you have eccentric aortic regurgitation, it actually can go and actually hit the leaflet there and cause the reverse doming of that anterior mitral valve leaflet. So I hope that is clear. Now, just few remarks on congenital mitral stenosis. We have few types of congenital mitral stenosis. First one is parachute mitral valve, as I already tell you. Number two is something that is called mitral arcade. So what is mitral arcade? It is when the chordae tendineae either it does not exist at all, or it is very, very short. So your leaflet is either it's attached to the papillary muscle straight away or only short segment of chordae tendineae. So that is mitral valve arcade. The patient can also have something that is called double orifice mitral valve, in which there is a bridge in between the two holes of the mitral valve. So this is also one of the variety of congenital mitral valve disease. Now, apart from the problem with the leaflet, you can also have other problems that cause obstruction for the blood when it moves from the left atrium to the left ventricle. One of the problems is called supramitral membrane. Supramitral membrane is the membrane that is below your left atrial appendage, so it's inferior to your left atrial appendage. Another condition is what we call a co-triatriatum sinister. Now, co-triatriatum sinister is a membrane superior to the left atrial appendage. Now, the way to understand co-triatriatum sinister is actually quite simple. So what happened during embryological development? So all four pulmonary veins actually converge to a structure that is called common pulmonary vein. And the common pulmonary vein should merge with the left atrium. So therefore, all the pulmonary vein drain into the left atrium. Now, in one extreme situation, all of the common pulmonary vein don't really go into the left atrium at all. So this is called total anomalous pulmonary venous connection. In co-triatriatum, so this common pulmonary vein is able to go into the left atrium. However, the membrane does not disappear or does not involute. So you have something separating the chamber with pulmonary vein and the distal chamber of the left atrium. So that is co-triatriatum, and we call it co-triatriatum sinister for the left part. I just wanted to tell you all that there is another condition that is called co-triatriatum dexter, but this is actually referring to the thing on the right side, which is in the right atrium. It's not exactly a membrane. So co-triatrium dexter on the right side is not a membrane like left side. It is usually just an eustachian valve, and it's a benign appearance. So that is co-triatriatum sinister and also supramitral membrane. This is another question that is favorite in echo board exam. So a patient has a mitral stenosis with E-wave deceleration time that is 100 milliseconds. So what is the mitral valve area? So they don't give you pressure half time. So you know that if you want to calculate mitral valve area from pressure half time, it is 220 divided by pressure half time. They give you deceleration time, which is 1000 milliseconds. So what is the mitral valve area? So the choice here is A, 1 centimeter squared, B 0.75 centimeters squared, or C you need more information, and D 1.5 centimeters squared. So this question actually try to see whether you can calculate the pressure half time or mitral valve area just by having deceleration time. So the answer in this one is 0.75 centimeters squared. This just testing you so that you know that pressure half time is equal to 29% of deceleration time. So pressure half time in this case is 0.29 times 1000. And when you get the pressure half time, you can put that as the denominator in your equation, and you can calculate your mitral valve area. Another thing that is more important, there is a formula that you can use straight deceleration time. It is 750 divided by deceleration time, and you can got straight your mitral valve area. Just wanted to remind you about the difference between pressure and velocity. Remember, when we look at the Doppler, the one that you see is velocity. So the decrease of half the pressure is equivalent to the decrease of 30% from the initial velocity. So that is the equation that I told you about just now. Now, the drawback of using pressure half time, number one, you cannot use pressure half time in patients with prosthetic mitral valve. And number two, you tend to underestimate the severity, and overestimate the mitral valve area. And this can happen, for example, in a lot of situations. In concomitant ASD, I will show you the diagram later. In concomitant aortic regurgitation, sudden changes in LA and LV compliance, or even diastolic dysfunction. This question, in microstenosis, the level of the valve at which narrowest orifice area most correctly measured can be identified from. So how do you ascertain, if you do 2D echocardiogram, that you are actually measuring at the smallest mitral valve area? Where do you ascertain that? Is it from parasternal long axis view? Is it from parasternal short axis view? Or is it from apical two-chamber view? Now, the answer for this one is from parasternal long axis view. So what do I mean by that? So if you look at the echo here, this is the parasternal long axis view of this patient. So we wanted to make sure that we cut right at the tips here. If you cut further down, you know that you will overestimate the mitral valve area, right? So that is how you do it. If you have 3D capability in your echocardiogram, you can actually do this, and actually you can just push a button and they can show you orthogonal view, and straight away you can get short axis view. If you don't have 3D capability, what you do is at the parasternal long axis view, you measure the distance between mitral valve leaflet. And then at the short axis view, you measure the same distance and see whether they are the same. If this is bigger than this, most likely you have been cutting in the wrong position. Wilkins score involve all of the following except A, leaflet thickening, B, leaflet mobility, C, leaflet calcification, D, subvalvular calcification, and E, subvalvular thickening. So Wilkins score is the score that we use to decide whether someone with rheumatic mitral stenosis is suitable to undergo percutaneous transmitral commissurectomy. There is 4: leaflet thickening, leaflet mobility, leaflet calcification, and subvalvular thickening. Okay, so they don't have subvalvular calcification. In Wilkins score, each of the parameters, and we have 4 parameters, we score from 1 to 4. So the minimum score is 4 and the maximum score is 16. Anything below 8 and below is considered very suitable for PTMC. From 8 to 11, that is a gray area. Sometimes you can do it, sometimes you're not able to do it. And more than 11, we usually don't do someone with a Wilkins score that is more than 11. So this is how you score in terms of the Wilkins score. I don't want to just go into details. You can read it yourself. Now, I just wanted to show you M-mode. Now, this is very important, M-mode, because as I said, it has very, very high temporal resolution. I just wanted to show you the normal movement of the anterior and posterior mitral valve leaflet. So this, what it looks like, M is anterior mitral valve leaflet, and you have W, which is the posterior mitral valve leaflet. So in diastole, they should separate. So the anterior and posterior leaflet should go to the opposite way. And this is the point. So you have a D point here, E point there, F point here, and then you have A, and you're supposed to have C right down here. If you have a bump here, that is called a B bump. Okay, that is a shoulder but it's called a B bump. That is not good. That means that the patient have increase in left ventricular and diastolic pressure to such a way that at end of diastole, the mitral valve leaflet can't really open, can't really close. It actually go up and open a little bit because of the high LVEDP. So this is the typical M mode that they might show you in the exam. So this is actually M mode of someone with rheumatic mitral stenosis. So how do you do that? How do you know that? So you can see that the anterior mitral valve leaflet is thickened, and also the posterior mitral valve leaflet is number 1. Number 2, you can see that this slope here is much shallower than this slope there. That's number 2. And number 3, you can see that the posterior mitral valve leaflet actually follow the movement of the anterior mitral valve leaflet. During diastole, it should go to opposite way, right? And you can also see the big left atrium here. I hope you can remember that. Now, what is the etiology of the mitral stenosis? And that is very important. So you can have rheumatic mitral stenosis. So this is the only mitral stenosis that you can use PTMC. You can have congenital mitral stenosis, and we have talked about this previously. You can have mitral annular calcification. In essence, this is just the same as your degenerative aortic stenosis. It affects normally the posterior mitral valve annulus before it crack up to the base and then to the leaflet body and finally to the leaflet tip. At the extreme, it can involve all the annulus and all the leaflet. You can also have radiation valvular disease. So this happened about 20 to 25 years after you got radiation. So remember that radiation can cause all sort of vascular complication, but radiation valvular disease is the one that is the latest one. And lastly, it can be also medication induced. It's not the last, it's like many reasons for patient with mitral stenosis. So you can also be due to, this also can be to medically induced. And remember this in mitral stenosis, when you want to calculate Wilkins score, you actually use the anterior mitral valve leaflet. What's the reason? The reason is the posterior mitral valve leaflet is immobile normally, so you don't use the posterior mitral valve leaflet. In MS, secondary to mitral annular calcification, you have calcification. You do not have the commissural fusion. When you don't have the commissural fusion, because you know that the reason we're doing PTMC to crack the commissure, so there is no point on doing PTMC with patient with degenerative mitral stenosis. What about radiation-induced mitral stenosis? So the place where the radiation-induced mitral stenosis happened is actually quite special. So it happened at the middle of the mitral valve at the body, and also at the proximal part of the aorta. So if I were to draw, so this is your mitral valve. Okay, so let's say that is your mitral valve. So that's your mitral valve there. Let me just clear a little bit. Okay, just do one more time. All right, so let's say this is your mitral valve, right, and that's your aorta, and that is your aortic valve. So this is the aorta. So where does it go? It goes usually from the body of the anterior mitral valve leaflet. So it starts usually there, up the way to the root of the aortic valve. So this from here to here is where the calcification occurs. So you can have problem in your anterior mitral valve leaflet, usually only at the body and the base, and also your aortic stenosis, and they can also affect the ostium of your coronary artery. So let's show you some cases. So this is a parasternal long axis view of an echocardiogram. So as you can see in this patient, just look at the anterior mitral valve leaflet here. There is no typical diastolic doming of the anterior mitral valve leaflet. And when you look at the posterior mitral valve, you can see bright echo-dense material here. Okay, so you start to think about yourself, what is the etiology? So when you see something like this that involve the base but not the leaflet tips, always think of degenerative mitral stenosis. Furthermore, in this situation, you can also see that the aortic valve also is calcified. When you look at the short axis view, you can see that the anterior mitral valve leaflet is free, but you can have calcification at the anterolateral side of the mitral valve. So that is the calcification. I just wanted to show you an important point. Look at this mitral valve, look at the posteromedial and anterolateral commissure. It is not fused. So this is not rheumatic mitral stenosis, and you cannot do PTMC on this patient. So this is a 78-year-old with rotary echo. So the diagnosis is degenerative mitral stenosis. Now, thankfully, patient with degenerative calcification of mitral valve rarely go to severe mitral stenosis. It can be, but it rarely goes so. But once it happens, it actually can cause a lot of trouble. Calcification of the mitral valve is actually very difficult to tackle when you do surgery. You are at risk of causing annular ventricular rupture if you try to debride the calcium forcefully. So you need to have a very experienced surgeon. Number two, I just wanted to remind you as well that the posterior mitral annular calcification, even though mostly it causes stenosis, it also can cause regurgitation when it can cause restricted closure of the mitral valve leaflet, just like how rheumatic mitral stenosis causes mitral regurgitation. Another reason is sometimes there is something that is called MAC attack, in which the calcium is so extensive and it go down to the base of the mitral valve leaflet, and it might cause mitral valve prolapse or flail. Okay, so that is something that you might need to take into account. The other thing is this degenerative mitral calcification is consists inside of calcium, and the calcium inside can liquefy. And when you liquefy, it can look like a mobile mass. And whenever you see mobile mass, you will be confused. Is this a clot? Is this an infective endocarditis? But however, if it's bright and you see it adjacent to the posterior mitral valve annulus, always be suspicious of caseous necrosis of the mitral valve, otherwise known as toothpaste tumor. Why do we call this toothpaste tumor? It's because if you were to do a surgery on this mass and you were to cut it off, you can see that inside look just like your toothpaste. And how do we manage caseous necrosis? So what happens is we just leave it as it is, unless it causes recurrent stroke or recurrent transient ischemic attack. Another thing that we can see from MAC is, so for example, if you have generalized mitral annular calcification that is circumferential, and let's say you have mitral regurgitation of mitral stenosis, this circumferential MAC actually provide a natural place where your transcatheter, the transcatheter valve can actually hang to, can sit on, right? So if you have MAC, you can actually do a procedure called valve in MAC. So people do this with Sapiens valve. They do transeptal puncture from right atrium to the left atrium, and then they just put a Sapien valve inside the mitral annulus, okay? And the MAC become the anchor. So just now was an example of degenerative mitral stenosis. This is another example of someone with mitral valve problem, but this patient have metallic, bileaflet metallic valve. So metallic valve can have three types: bileaflet, single tilting disc, or ball and cage. So this is the commonest one, the bileaflet. I just wanted to show you the utility of transesophageal echocardiogram. You can see here, there's two leaflet here, and one leaflet is definitely not moving. So you can actually tell that one leaflet is not moving. From the 3D echo also, you can see beautifully, one leaflet is moving and another leaflet is not moving. You can also see the sewing ring here, and that is the left atrial appendage on the lateral side. So this is a surgeon view. So whenever we do a 3D echocardiogram, what we do is we rotate the picture to such an extent that the aortic valve is at the 12 o'clock position. The appendage is a lateral, and you have interatrial septum at the medial side. Okay, so this is your on-fast view. That is your tricuspid valve. So this patient obviously have dysfunction prosthetic mitral valve. So one of the leaflet is not moving. So you have to find out what is the reason. The reason we have for dysfunction of prosthetic valve is three. So either it can be due to structural valve degeneration, which is SVD, because of degeneration, calcification, or tear. More commonly for metallic valve is from valve thrombosis, and it can also be from infective endocarditis. And you can see in this patient, the mean gradient across the start mitral valve is at least 25 millimeter mercury, so it's very high. You can see that the peak velocity is also 3.2. I start to get worried when the peak velocity across prosthetic valve cross the threshold of 1.9 meter per second. What about pressure half time? So I wanted to remind you that we don't use pressure half time to calculate mitral valve area in patients with prosthetic mitral valve. What we do is we use continuity equation. So what come into the left ventricle through the mitral valve, provided there is no significant regurgitation in the aortic or mitral valve, is the same as what come out through the aortic valve. So the thing that goes into the mitral valve, so that is the mitral valve VTI times the mitral valve effective orifice area, is equal to LVOT VTI times the LVOT area. So you just rearrange the equation and you can get mitral valve area. So if I were to show you here, how do I do this? So I know that mitral valve VTI times mitral valve area is equal to LVOT VTI times the LVOT area. Okay, so this is the equation. So what I do is I just rearrange the equation to get my mitral valve area. So mitral valve area is equal to LVOT VTI times LVOT area over the mitral valve VTI. All the things you can get from here. So I hope that is clear to you. So remember, when you do the MVVTI, use the CW. Why CW? CW is where you measure the fastest flow, and the fastest flow is where your smallest orifice area is. So don't use pressure half time. You can use pressure half time to suspect that you have some obstruction or regurgitation, but you don't use it to calculate mitral valve area. Now, faced with mitral stenosis patients, so what you need to do is, number one, you have to ask how severe is the mitral stenosis. Remember, only severe disease warrant intervention. Is the patient symptomatic? And the combination of severe and symptoms is usually a ticket for you to go for operating theatre, regardless of the function of the ventricle itself. However, now we sometimes even more strict that we go for intervention for severe patient, even if they are not symptomatic. We look at whether the LV got dysfunction or not. Even if the LV is preserved, we still sometimes in a certain situation go for intervention. Always have to ask ourselves, what is the pulmonary artery pressure? Pulmonary artery pressure that is more than 50 or 60 millimeter mercury is a worrying sign that might warrant intervention. How suitable is the patient if they have rheumatic mitral stenosis to undergo PTMC? And one thing that I wanted to remind everyone, and also myself, is the fact that you need to exercise the patient. If let's say they have symptoms on exercise. So you do this for your patient with coronary artery disease, and the same goes for patient with valvular heart disease. If they are asymptomatic at rest, stress them. If they have not severe, they say moderate mitral stenosis, and they have symptoms, so what you do is you do stress test and you see, sometimes you can see the gradient go up so much. So I give you an example. Let's say you have someone with mitral valve area of 1.7 centimeters squared. You try to find other cause of their symptom, you cannot find. You see their beam gradient is only 7 millimeter mercury. So you exercise them. If you see the beam gradient go above 25 and the systolic pulmonary artery pressure go more 60, that is actually an indication to intervene. The mean gradient that is more than 10 across mitral valve is considered significant, meaning that it is severe. So what we do, how do? We put a continuous wave Doppler across mitral valve and we trace the envelope, and the computer will calculate the mean gradient. But just be cognizant by the fact that the gradient is heart rate dependent. So oftentimes, patient with heart rate of 60 beats per minute might have gradient of 6 or 7. But once it go into tachycardic, then the gradient become higher. That's why patient with pregnant lady have gradient that is high, because they tend to be tachycardic. Use beta blocker to slow their heart rate down. As they go to 70 or 60, they will feel much better. In addition to furosemide if they are overloaded. In prosthetic mitral valve, one of the markers that I use to suspect dysfunction is when the mean gradient across mitral valve is more than 5 millimeter mercury. Then I try to investigate further. In native valve, as you know, planimetry is the gold standard for rheumatic mitral stenosis. If you have 3D, do that. And I like to do that when I do my transesophageal echocardiogram. We do what we call multi-planar reconstruction. So we use from different plane to make sure that we cut exactly the place where the orifice as its narrowest. Planimetry is the gold standard. So I already told you how to make sure that you cut correctly. So we've talked about this before. And make sure if you don't have 3D, just make sure that the distance between this and this is about the same. The pressure half time, the concept of pressure half time is the time for the pressure of the left atrium to left ventricle to equilibrize between one another. So pressure half time is the time where the pressure go to half its initial maximum value. So how do we measure this? Now the problem is when we do echocardiogram and we put our Doppler doesn't measure pressure, it actually measures velocity. So what we wanted to do is, rather than looking at when the pressure go into half, because the Doppler doesn't measure pressure, we look at velocity. The pressure reduction by 50% is equivalent to velocity reduction by 30%. So you go from, let's say you start with 1 meter per second. So you want to know the time it takes for it goes from 1 meter per second to 0.7 meter per second. Okay, so 30% less. So this example, this orange line is the left atrial pressure. This red line is left ventricular pressure. So what you wanted to know is the time it takes for the pressure to go from maximum to half its value. If we to rearrange the equation, when we this is the, let's say, the tracing in the hemodynamics. If you change it to Doppler tracing, the Doppler will only show velocity. So we wanted to know the time it takes for velocity to reduce from 1 to 0.7, or anything that is 70% the initial value. So that is pressure half time. Now if you rearrange the equation, pressure half time, and input as a denominator and 220 as numerator, then you get the mitral valve area. So as the pressure half time goes up, the mitral valve area go down. As the pressure half time go down, the mitral valve area go up. Now, because of this fact, okay, we talked about this before, that pressure half time is 29% of deceleration time. And you can just remember this formula, it make it easier. So you bypass this equation at the top. So what happened? If you use pressure half time, say you were trying to find the time for this pressure inside the left atrium and pressure inside the left ventricle to equilibrate. So if you have atrial septal defect, what happened? So the pressure inside the left atrium now can release not only to the left ventricle and also into the right atrium. So what happened? The time it takes for it to equilibrate become faster because it now go to two orifices. What about non-compliant left ventricle or non-compliant left atrium? Is the same. If you have non-compliant left atrium, the left atrium is more stiff. It's become more stiff, it pushes the blood more towards the left ventricle. So the pressure half time will become shorter. So in both these situations, again, you underestimate the severity, you overestimate the mitral valve area. Ditto, someone with acute severe atrial regurgitation or someone with non-compliant left ventricle. Again, the left ventricular diastolic pressure is high. It takes shorter time for the LA and LV pressure to equilibrate. Again, you have short pressure half time, overestimate the mitral valve area, underestimate its severity. Now let's look at the concept of PTMC for rheumatic mitral stenosis. The main reason we do PTMC is to crack the commissure. We use something that is called in-way balloon. Because we were cracking the commissure, before we start the procedure, it is very important to demonstrate the presence of commissural fusion. If there is no commissural fusion, there's nothing to tear. And it follows that after the procedure, you have to actually demonstrate that you actually have already cracked the commissure. So this example of commissural fusion, you can see here clearer in the anterolateral commissure. Now, regardless if you have only one commissure fuse or both commissure fuse, you can also do PTMC. And what is Wilkins score? I've told you Wilkins score is a score that shows the probability of success when you do PTMC. So score 8 or less, meaning that the patient is very suitable. If you go from 8 to 11, it's gray area. More than 11, usually it is not successful. So we go usually for operation. So it is mobility. So for example, if it's moving freely, it's 1. So for example, if move only a little bit, that is 4. What about thickening? If the rest of the mitral valve is less than 3 millimeter thick, that is 1. If let's say it's 3 to 5 millimeter, maybe it is 2. If let's say it is more than 8 millimeter, the whole length of the anterior mitral valve leaflet, maybe it is 4. What about classification? If there is no classification, it's 0. Classification of the leaflet tips only, it is 1. If less than half, it is 2. If it's half of the leaflet, it is 3. If the whole of the leaflet, maybe it is 4. And lastly, the involvement of subvalvular thickening. Okay, if the subvalvular thicken as well. And as I said, the minimum score is 4 and the maximum score is 16. So this is an example of how we score Wilkins score, right? So this is mobility, thickening, classification, and subvalvular involvement. And you can read this at your own leisure. So this is an example of apical long axis view of someone with thickened chordae tendinate. Now let's do some cases. Okay, 42 years old lady with exertional dyspnea. The patient have no other comorbids. Just give me a moment. Patient have no other comorbid, then let's look at the echocardiogram, the patient echocardiogram here, right? Now look at the parasternal long axis view here. Now, even though there is no obvious thickening of calcification, you can see the movement of the anterior mitral valve leaflet. There's obviously, let me show you, there's obviously doming of the anterior mitral valve leaflet and the reverse hockey stick sign of mitral stenosis. So you know that is rheumatic mitral stenosis. Now the question is, if this were to be severe mitral stenosis, what would you do for this patient? Always think of PTMC first, and let's try to calculate the Wilkins score together. So in terms of the mobility, okay, maybe it's slightly restricted. So from 1 to 4, I'll give 2. In terms of thickening, there's not much thickening, so I'll give 1. In terms of calcification, I don't see any bright white thing here, so I'll give 1. So far the score is 2, 3, 4, and I will see the subvalvular thickening. From here, the subvalvular looks okay, but just let's say that the subvalvular thickening is 2 points, so we have overall 7, so this is very suitable for PTMC. Now, what we want to look in the short axis view, we want to see commissural fusion. Okay, so you want to see commissural fusion that I show you. That's anterolateral commissural fusion there, and that's the posteromedial commissural fusion there. So we have something to crack. And we can also planimeter this. So when you planimeter, the area is 0.9 centimeters squared, and the Wilkins score, just now I said is 7, but in my slide it is 5. So regardless, both are suitable for PTMC. When we look at the mitral valve, this is the continuous wave across the mitral valve. So the computer will actually calculate for us what is the mean gradient, and you can see the mean gradient is 21 millimeter mercury. So it's way, way severe. What about the mitral regurgitation? You can see that the Doppler is parabolic and it is not tense. So this shows that the patient have mild mitral regurgitation, which is not a contraindication to do PTMC. The maximum pressure of the TR is about 3, so 3 meter per second. If you put in the Bernoulli equation, it will be about 36 millimeter mercury. Now, if we were to calculate systolic pulmonary artery pressure in this patient, okay, maybe it's a bit more than 3, and we calculate it to be 48 millimeter mercury. So there is pulmonary hypertension, but they are not severe. So what will you do? So this is a patient with suitable case of PTMC. In fact, the right atrial pressure is also low. The width of the IVC is only 1.7 centimeter. What about second case? So we have a 52 years old man with dyspnea and occasional palpitation. All right. Again, look at the echo here. Okay. Now again, you can see the thing that we have come over and over again. You can see the diastolic doming of the anterior mitral valve leaflet here. So again, you know that we are dealing with rheumatic mitral stenosis. Now, when we put in color view here, unfortunately, you can see moderate mitral regurgitation. So the valve is leaking. So when we want to tear something in PTMC, we're only going to make the mitral valve regurgitation worse. Let's say we want to do the Wilkins score for this patient. The mobility, maybe I will give this 3. Calcification, I will give 2. So 3 plus 2 is 5. In terms of thickening, maybe 2. So 7. In terms of subvalvular involvement, maybe 1. So it's 6. So in terms of Wilkins score, it is still possible. But the problem is the patient have moderate mitral regurgitation. So that is a contraindication for PTMC. Now, if you look at the mitral valve, you can see compared to our patient previously, the mitral valve Doppler shape is quite dense. You can see it's quite wide here. So that is something that you have to be aware. So when we look at the mitral valve area from pressure half time is 0.71, we can use pressure half time because this is a native mitral valve, and the mean gradient is 11. So the patient does have very severe mitral stenosis. It's just that we don't know whether this patient, we don't think that this is suitable for PTMC. So in this kind of patient, what we need to do for this patient is we need to send the patient for mitral valve replacement. Let's look at another case. So we have 19 years old female with atypical chest pain. A planimetry shows mitral valve area of 0.7 centimeters squared. So that's severe mitral stenosis. A mean gradient across the mitral valve is 36 millimeter mercury. And you are seeing the patient in clinic and considering her options. So look at this here. So that's a parasternal long axis view. Now looking at the echo here, if we pause, there might be a suggestion of diastolic doming of the anterior mitral valve leaflet, but it is not so much. Now apart from that, there is no other thing to suggest mitral valve leaflet pathology. Okay. Now, However, when you look at the parasternal long axis view, there is a suspicion that these two leaflets is actually attached to only a single papillary muscle. Okay, so now our mind is thinking about parachute mitral valve. And when we go to our short axis view here, we actually confirm our suspicion. So we can see that the patient only have anterolateral papillary muscle here. And this mitral valve is actually attached to only a single anterolateral papillary muscle. So this is a patient with parachute mitral valve. And obviously, patient with parachute mitral valve, we don't send for PTMC. So this patient need valve replacement. Let's look at another case. So we have 56 years old lady with history of dyspnea with underlying lymphoma in remission. A planimetry shows mitral valve area of 0.7 centimeters squared with mean gradient of 22. So this is very severe mitral stenosis. So look at this, okay? Now, even though the patient have radiation disease, don't let them distract you, okay? It is of course possible that the patient have radiation-induced mitral valve disease. However, in our society, what is this? This is classical reverse doming of the classical reverse hockey stick sign and diastolic doming of the anterior mitral valve. So this is rheumatic mitral stenosis. Look at the mitral valve unfast here. So you can hear that the posteromedial is fused and actually very calcified. Then the anterolateral is also fused. So in this patient, let's try to see the Wilkins score. Maybe the movement I'll put as 3 in terms of mobility. In terms of thickening, I will put as 2, so it is 5. In terms of calcification, I didn't see many calcification. I'll give 1, 6. Subvalvular, maybe I will give 2, so it's 8. So this patient with rheumatic mitral stenosis, Wilkins score of 8. So this is also suitable for PTMC. We also have demonstrated the presence of commercial fusion. So this is a typical rheumatic mitral stenosis. The valve looks suitable and the patient should be sent for PTMC. Now, what are the things that we need to look for? When we want to do PTMC on a patient, don't forget the right side of the heart. You know that anything that affect the left side will affect the right heart. See how bad is the concomitant tricuspid regurgitation. Now, if you have mild or moderate tricuspid regurgitation, you can go and do PTMC, and you can hope that the tricuspid regurgitation disappear. However, if there is concomitant severe tricuspid regurgitation, it's better to send the patient surgery so that the surgeon can actually do concomitant tricuspid annuloplasty. Now, you can see here the survival for mild tricuspid regurgitation and moderate tricuspid regurgitation undergoing PTMC is the same. However, if you have severe tricuspid regurgitation undergo PTMC, the outcome is poor. So rather, it's better for you to go for surgery. Basically, in terms of the summary of when you're not supposed to do PTMC is number 1, the patient with calcific degenerative mitral stenosis, so degenerative posterior mitral annular calcification, patient that have moderate mitral regurgitation and above, patient who have high Wilkins score, patient that have left atrial or left atrial appendage thrombus. You see the valve and the valve look like need to tear, so you don't want to do that. Someone with concomitant severe tricuspid regurgitation. You do not want to do it in someone with congenital mitral stenosis. Now let's look at the guideline and try to understand the guideline. In understanding the valvular disease, so what happened is American Heart Association and American College of Cardiology has come with staging of mitral valve issue, just like heart failure. So there's stage A, stage B, stage C, and stage D. In terms of understanding, so stage A is when you are at risk of having a particular valve problem. For example, you are an elderly, you have coronary artery disease, you have at risk of developing aortic stenosis. Or, for example, you are a native of a place that is endemic of rheumatic valvular heart disease. So you are at risk of having rheumatic heart disease. So that's stage A. So what about stage B? Now, stage B is when you already have, when you look at echocardiogram, the structural abnormalities of that valve. And this is anything that is less than severe. Okay, if it's severe, that is a different class. So anything less than severe, mild or moderate, that is stage B. Now, stage C is severe. Okay, stage C is severe. Now, stage C is divided into 2. That is stage C1 and stage C2. Stage C meaning that you are severe and you are asymptomatic. Okay, C, you are severe and you are asymptomatic. In stage C1, your left ventricular function is still preserved. In stage C2, your left ventricular function is already decompensated. So if you have stage C2, then you have to intervene on the patient. If you have C1, they are asymptomatic and the LV function is okay, you might want to wait and see. And the last is stage D. Stage D is symptomatic and also severe. So for patients with rheumatic microstenosis, if they are stage B, which is progressive microstenosis, if they are asymptomatic, we don't do anything. If they are symptomatic, but we know it's from other causes, we don't do anything. If they are symptomatic and you cannot find what is the reason they are symptomatic, do an exercise stress test. If the mean gradient then go above 25 millimeter mercury, or the pulmonary artery pressure go above 60 millimeter mercury, that might be an indication for you to do PTMC. The American Heart Association also have changed the threshold of microstenosis. So less than 1 centimeter squared now is considered very severe microstenosis. And this is similar to aortic stenosis that is less than 0.6 centimeter squared. So those that have less than 1 centimeter squared, even if they are asymptomatic, if the valve is suitable for PTMC, you can straight away go for PTMC. What if you have someone with less than 1.5 but more than 1, so 1.3 centimeters squared, for example, and they are symptomatic? This is actually class 1 for you to do PTMC. Okay, so in summary, stage B, you just follow up. If let's say they are very severe, you do the operation, you do the PTMC, regardless of whether they are symptomatic or not. If they are severe and they are symptomatic, then you do the surgery. What if they are severe but they are asymptomatic? Now you have to look at whether there's any sudden onset of atrial fibrillation or their pulmonary artery pressure is elevated. Then you might also consider to do surgery in this patient. So what is the take-home point for our talk today? So I have told you the different type of microstenosis, paying particular attention to rheumatic microstenosis. Take-home point here, number 1 is remember the way to assess mitral valve area. Make sure you assess a correct mitral valve area, and also its limitation, such as you don't use planimetry for prosthetic mitral valve. You don't use pressure half time to calculate the mitral valve area for prosthetic mitral valve. First line treatment for rheumatic microstenosis is percutaneous transmitral commotiotomy. Make sure a correct patient selection. The score is counted by looking at the anterior mitral valve leaflet. Make sure there is commissural fusion, and make sure patient does not have concomitant severe tricuspid regurgitation or left atrial clot. Remember, echo is what they call a zeitgeist. Oh, not zeitgeist, they call it a gestalt, a combination of every little parameters. So you consider all the parameters before deciding on treatment. So I think that's all for today. We're going to talk about some other things such as IT regurgitation in other session. Now, thank you very much for your attention.